Good morning, everyone. It's a pleasure to be here. We're going to be discussing light-based treatment, no financial disclosures, and I want to kind of just give an overview of the glaucoma journey. Again, glaucoma is not a death sentence, but it is a life sentence. The good news, though, is that in general, it progresses slowly, and early on, it's quite asymptomatic. This is why screening and getting your annual eye exams is so important. Careful monitoring is required, though, and this is a big emphasis because delay in intervention, especially very, very early on, only minimally impacts the final outcome. So we want to make sure that you actually have the condition, get a sense of what your maximum pressure is, and just really monitor, really emphasize monitoring early on. And then we determine what absolutely needs to be done now versus considering the risk of delay, and we invest in diagnostics early on rather than therapeutics. Life expectancy, of course, is important too. When you're in doubt, always ask your clinician, what would you do for yourself or your own family member? This is the overview of today's talk. When we look at SLT, it stands for selective laser trabeculoplasty. It was first described in 1998, so it's been around for a couple decades now. And why is it selective? Well, it's Q-switched. It's not continuous wave. In other words, lower energy delivery. You don't get burning of tissue. You don't get thermal damage or scarring. Complications are infrequent. Some people get a pressure spike or prolonged inflammation, and occasionally we get corneal swelling. The cellular response isn't fully understood to this day, but it's believed that there's photoactivation. The light itself is stimulating cells to make cytokines. These chemicals then recruit macrophages to remove cellular debris at the trabecular meshwork. It's kind of like activating your own biological liquid Drano. That's what I like to tell patients. Unfortunately, it's not for everyone. If your angle's narrow, we can't do it, or if you have scarring in the angle, if you have active inflammation, or very severe and advanced glaucoma, it's not quite appropriate, or some of the developmental anatomical glaucomas. This particular treatment, SLT, has really come to the forefront as a first-line treatment because of the LIGHT study, laser in glaucoma and ocular hypertension. It's a big study, randomized clinical trial out of the UK, looking at patients who never got treatment with open-angle glaucoma or high eye pressure, and it randomized SLT to drops, and this is what they found. It's pretty much equivalent. So the patients, though, in this particular study who had SLT first actually did better in terms of prolonging visual field function. So what is it like? What does it feel like for you? This is what it feels like. You'll sit at the exam, slit lamp exam, just as you would during your regular eye exam. The only difference is your ophthalmologist is going to put a lens on the surface of the eye. First, there's going to be an anesthetic drop. There'll be some solution, gel, liquid, coating the lens as a barrier between your eye and the lens, and then the lens floats on your cornea of your eye. Why do we use a lens? Well, the angle is recessed. When we look directly at your eye, we can't see it. It's recessed literally in an angle, so we need the mirror within the lens to bend the light to focus directly into the angle. The key for you, and I tell my patients, you have one job. First of all, keep breathing. Second of all, don't kick me. Third of all, hold your head still. That's all you have to do. Once you're comfortable, then we'll be done in 5 to 10 minutes. You may feel a little bit of a bee sting, a little bit of a pin prickling sensation, and you'll see flashes of light. That's normal. And then we like people to wait a while, just kind of hang out in the office or go get coffee and come back, and then we check your pressure before you go home. Just for safety's sake, since you will have gel on your eye, say, you know what, don't drive afterwards. Take a bus or Lyft or Uber. You will get an ache. There is inflammation everybody gets that for 3 to 4 days, and the full effect of the laser may take 6 to 8 weeks. There is a new type of SLT called direct SLT. The advantage here is that it is non-contact and it goes through the sclera. It doesn't go directly into the angle. It's automated. Because it doesn't go through the cornea, if your cornea is a little bit cloudy, that's okay. It was FDA approved in December of 2023, so we're still getting information about this. In general, though, for any of these light-based treatments, you have to be realistic. Like any medication, any treatment, there's always going to be a certain percentage of people who don't respond, unfortunately. And the eye pressure reduction is unpredictable. Some people do get a great response of 20 to 30%, but some people only get a partial response. However, it can delay the need for medication, and that's the key. It delays the need. It's not a cure. It is temporary. We can repeat the laser. On average, it lasts about 3 years. Some people may get a year or two. Some people may get 5 years. Again, the length of duration for any individual is temporary as well and unpredictable. So we continue to need to follow you closely to see when your pressure starts to rise again, to decide should we do another laser or institute drops. And of course, there are always potential side effects. Thank you. And I'll introduce Dr. Ewa.
Nice job. Thank you, Dr. Pickering. Great review. There are other types of lasers. We've talked a little bit about SLT. Financial disclosures, I will actually was asked to add a topic by a product that's made by Itronics. I think you'll find it very interesting, but I do want to disclose that I'm a consultant and recently became a shareholder. Probably you'll see why in a minute. Going back to the slide that Dr. Pickering showed, these are various factors, and as you sit here, when you get the diagnosis of glaucoma, that right away impacts your quality of life. And as I look across this room, almost always we can keep you seeing for the rest of your life. So there are exceptions. In general, this is a slow-moving disease. And one of the factors to kind of look at this roadmap is your age, because that changes things. If someone comes in, they're 85 years old, then the expected life expectancy will make a difference. If I have a younger patient, or certainly a child, or so forth, so that actually plays a role. But the question is, so how long are you going to live? Well, here, how much you calculate it. So this is from a financial website. I have no financial interest in it. There's a QR code for those who have phones. And you ask a bunch of about 8 to 10 questions, and it makes a prediction. And actually, I started looking at this. If you're interested, it's a completely separate topic. I got started on a GLP-1 agonist about 3.5 years ago, and it added 10 years to my life, roughly, based on these projections. So I don't suggest you use this to determine how you're going to treat your glaucoma. But it is kind of fun, because you change different variables, and you can see what the importance is. And the bottom line is stay healthy. Don't smoke. Do some exercise. Now this is actual data, which in this group you would never probably see. This is when we, in the clinic, see a patient. We have to code. This is how the clinic gets reimbursed. So this shows what is actually being done across the United States. This is what's called Medicare data. And lots of different lines here. But I'll draw your attention to that red line. That red line is something called trabeculectomy. It's a type of a glaucoma surgery that creates what we call these filtering blebs. Those more commonly done procedures you'll see are in the more recent past. And these are these new MIGS procedures that are ideal to be done at the time of cataract surgery. But so the question is, why did this drop off so significantly for this procedure, which used to be done so often? And the reason is, unfortunately, with these, what we call bleb-producing surgery, so they're kind of like a blister area. We create a little area for this fluid to flow out. And so those areas, unfortunately, can be at risk for injury or infection. And so although we're happy as surgeons that the pressure's low, it can give you problems down the road. For some patients, under certain circumstances, still a very reasonable option, but we saw that as potentially an issue. And so more recently, in the last couple of years, more data out of Japan showing over time, because it's a long-term chronic disease, that there are some issues with these filtering blebs. So is there a better or different way? And so looking now at that same data, but focusing on these procedures, and again, most of you here will only need some eye drops, maybe a laser treatment. You won't need these more invasive procedures, but if you do, you'll notice there are 2 other lines there. The yellow one is for something called these implants or glaucoma drainage devices, and the green line is for this laser that I'll get to in a minute, which is linked to this talk. And so these drainage devices, there are different designs and different types. What they do is, the basic design is there's a plate and a little tube that then we put into the anterior chamber. That's where the fluid is produced. And what it does, it takes it further back. Unlike that picture where I showed these kind of blister areas towards the front and they're exposed, it kind of moves the action back. And over the last 15, 20 years, we've modified how we actually do these implants so their safety profile got better. And our group in the early 1990s was doing we continue to do research, but we were looking at different lasers. And we realized back then that this other type of laser procedure, not SLT, called a laser cyclophotocoagulation treatment, I'll show you a diagram in a minute what that means, combined with these drainage devices really can work quite well. And so this is my first Gemini created diagram I'm showing in a lecture. I asked it, would you please create me a diagram comparing diode laser and cyclophotocoagulation? Doggone, it did pretty well. So as you saw in Dr. Pickering's talk with SLT, it's in the front of the eye. Back here, it's called the ciliary body. That's where the fluid gets produced. And it was talked about earlier, it is a kind of a plumbing issue. So the drainage device creates a new drain, whereas the diode laser actually reduces the fluid production. And what we found in the early 90s that combination can be very potent. And this is actually some of our data. This was published a couple of years ago. When you look at data from surgeries, if you ever get interested in or have trouble falling asleep, you can read some papers. But it shows that usually for a year or two, our average here was 7 years. So we waited to publish until we had a lot of data. So at our center, for all of us, our surgeons, really prefer this approach. The other approaches are good also, and they have other advantages. Nothing is perfect, but we found this to be very useful. Now, how do you decide as a patient what to do? And one of the most powerful questions you can ask is, what would you do for yourself or a family member? Without that question, I'm going to tell you about studies, means, and averages, but we don't treat means and averages, we treat individuals. And so you may be surprised that sometimes when you ask a doctor what they would do for themselves or what they would do for a family member might be a little bit different than what we would kind of go down our standard protocols. Now, a couple of words about this other topic, completely unrelated right now to lasers. In 2017, this device was available in Europe. And it kind of sounds too good to be true. That's why I got interested in it. And what it does is it's this goggles that puts electrodes on the front here, through here, and also on the back of your head. And it generates, non-invasive, this electrical stimulus. And electrical stimuli to other neurologic diseases have been shown to be useful in other diseases. And what it does is it creates this little current. And in Europe, this is already approved. And again, it's not going to take someone who doesn't see anything to someone who goes all the way, but there is evidence that in some patients, depending on roughly maybe 50, even to 70%, depending on the diagnosis, it actually may not only stabilize, but actually may improve, which is really incredible. Our center was the first in the United States to have access to this. And the reason I also wanted to share this with you is there is we currently have a study that we're doing. You can go to Europe and do this, but it's quite expensive to do. But at our center, if you qualify for our study, we'll be happy to enroll you, but it's a very specific protocol. My associate, Dr. Radhakrishnan, is the principal investigator on this study at our center, but if you can look at research@glaucomasf.com or email any one of us here at GRF, we'll get you in touch. And then we'll give you the instructions of how to proceed, because we need to get specific data to review to make sure that you're qualified. And if you are, we would certainly enter you in the study. We still have openings in our study. And just to let you know who is who, so you'll be wanting to look for Dr. Radhakrishnan. She's right here. She told me she'll get here at lunch, and she'll be here this afternoon. By the way, this is our team, and you may have met Dr. Lynn, Dr. Pickering you just saw, but actually, we stand on the shoulders of these giants. Dr. Hoskins, Hetherington, and Schaefer, this was their practice, and we're honored to have continued their tradition of focusing on the patient, not only their vision, but their quality of life. And finally, just a little fun, if you look at your program, I think there's a reception later tonight, is that correct? And so I think, now alcohol has problems, but I'll give you an interesting fact to think about. This is data from 1986, which looked at the effects of different things, including alcohol. And at our center, this is our building downtown, about 7 blocks from here, but I make an arrow because it's a separate entrance to a bar. Now, alcohol has problems, but just to let you know, alcohol does lower intraocular pressure. But let's be more specific. So the peak effect is at 20 minutes. And as you can see, at about 45 minutes, you could probably have to redose. Now, the problem is, well, why don't we just treat patients with drinks? Well, the problem is, well, you can't do much, and it burns out your liver. But nonetheless, if you happen to enjoy the evening, if you're staying overnight in San Francisco, the bar is open on Saturday nights. Great food, good drinks. I have no commission from it, but it's a lot of fun. And with that, thank you for your attention.